Here you can see our preoperative imaging. This is a patient with severe stenosis, really from C5 to C7. And the indication for corpectomy is retrocorporal disease or retrovertebral body disease. So she's got stenosis at the C5-6 disc space and the C6-7 disc space, but also behind the C6 body. And you can see she's got core signal change there as well in the typical snake eyes pattern, which fits with her myelopathy, which means she needs an operation. Now we are looking at the anterior cervical exposure from the left side, and we're looking at the C5 to C7 bodies and the longest collar retracted. First, we use Lexel to remove the anterior osteophytes from C5, C6, and C7. Then an 11-blade knife is used to incise the disc at C5-6. High-speed burr is then used to start the C5-6 discectomy. This level was quite collapsed, and we had to drill off a good amount of the inferior C5 end plate and C6 superior end plate. And when burring and drilling off bone, when doing a corpectomy, it's best to err on the corpectomy side. So we can remove as much of the C6 body as we need to because that bone is going to be removed anyway. Whereas I really want to respect the inferior C5 end plate because having that hard cortical end plate is going to be really helpful for not avoiding subsidence. Then we get a cob in to make sure we're in the right space and facilitating movement. Then we get the diamond burr that is used to further widen the disc space so we can see. And again, we're preferentially drilling on the C6 body inferiorly, trying to respect the C5 inferior end plate. That C6 body is going to be removed in entirety, so we can drill off as much as we need to. Now at this point we've gotten past down to PLL and we're coming through PLL with a nerve hook and 1 and 2 kerrison, trying to get down to dura. There was a good amount of redundant PLL here, so it took some time. And then going up from 1 kerrison to a 2 kerrison to see the dura and further remove PLL. And all this will be removed with the corpectomy, so we don't need to remove all the PLL, really just need to get through dura so we know our depth for the corpectomy drilling. Hemostasis is then achieved at the C5-6 level with Surgiflow and a cottonoid. We then move down to the C6-7 level. We again use a Lexel to remove any anterior osteophytes and get access to the disc space. A knife is brought in to incise the annulus. Curettes are used to remove the disc. High-speed burr again is used to widen the disc space, and again, preferentially we're drilling cranially now because again we want to respect the inferior C7 end plate. We can drill off as much as C6 as we need to visualize the 6-7 disc space because that bone is going to be removed anyway. We further drill off more of C6 to visualize and get down to dura safely, avoiding to work in a narrow hole. A cob is then again brought in to confirm we're in the right direction and right plane. Burr is used again to get down to PLL and visualize the disc space. A nerve hook is used to come through the PLL and elevate it while our assistant removes the PLL. Now we have a good shot here of both discectomies. There's intervening C6 body in the middle. As soon as the screw touches the dura from the body, we usually go up 2 millimeters from that. So if we had a 16 millimeter screw from anterior body down to dura, we'll use an 18 millimeter screw. So at this point, we take a high-speed burr and just drill troughs bilaterally. And we know our depth because we've gotten down to dura safely there. And the diamond is good here to avoid bleeding. We continue to use the diamond burr on both sides. Now drilling is done with a diamond burr on the patient's right side until we get down to PLL or dura, and we can see that the intervening C6 body is starting to get loose, and then it's removed with a Lexel. Here it's removed into 2 pieces, it broke in half, so now we remove the rest of it. And all this autograft can be used for filling the central canal, the open canal of the allograft bone. So now that our C6 body is removed, we got a nice dural border, and we're further removing PLL at the edges to make sure that the dura is free and the decompression is adequate. Flow seal and cottonoid are used to obtain hemostasis. And at this point, we kind of let that chill while we fashion this allograft. And this was humerus, which is nice. Humerus is our preferred allograft because it's usually really big if the patient's anatomy can accommodate it, which is better than fibula. So we've cut this into size and fashion so we can get right into the disc space. We use a tamp and a mallet to get into the disc space. And there's always a little bit of a gap at the edge, and these can be filled in with extra pieces of bone from the allograft. see we have a small piece there that we're trying to fill in that gap just to get good end plate contact. That broke in half, but we still were able to wedge some bone in between that gap that was right there, and we do that further. And we do a little bit on the caudal end as well, and trying to get as much bone into any of these wedges, these open areas as possible to maximize end plate contact. You can see a large humerus allograft packed with autograft and DBX, and then getting as much bone as possible. And then we get a plate and we bend the plate to fit the spine. To put the screws in, we use a burr to break the cortex and go straight to screw. And these are nice long screws. We try and get as long as possible, almost to the cortical edge, at minimum greater than 70% of the body for a screw length. And these are 18 millimeter screws that we use in this case. Get good fixation. The plate is then final tightened, and then final x-rays are taken intraoperatively and postoperatively. And at this point, hemostasis is critical. Once you get the plate locked, spend a good 5 to 10 minutes getting hemostasis to avoid any anterior cervical hematomas. And now postoperatively, you can see AP and lateral x-rays. We have a nice large humerus allograft in the corpectomy defect, also with a plate anteriorly with nice long screws that are almost to the cortex, but take up at least 80-90% of the body for good fixation that will hopefully promote a successful fusion.